Thank you, Rama. So an ideal tonometer should measure in true intraocular pressure, continuously, indirectly, be precise, reproducible, and not be influenced by corneal properties. The dynamic contour tonometer was presented as a new tonometer at Cangrisa et al. It is based on the Pascal's principle, which states that the pressure on an enclosed system is passed undiminished to all the other parts of the system, including the walls of the container. So therefore, when contour tip is applied to the when a contour tonometer tip is applied to the surface of the cornea assumes a neutral shape, and therefore any tangential forces or any forces bending the cornea are cancelled out, and the pressure on the external surface of cornea is equivalent to the pressure on the internal surface. And this is measured by a pressure sensor which is placed in the center of the tonometer tip. So these are the components. You have a This is the sensor tip which is carried on the cantilever, which is attached to the slit lamp by its foot plate. This is the liquid crystal display which displays the readings. This is the sensor cap which has to be placed on the tip at all times to prevent injury to the tip. And there is a wireless printer if you want to take a printout of the actual measurement. So when you need to take the measurement, the patient is placed in the slit lamp, topical anesthesia needs to be used. And first, this blue knob here has to be turned just 10 degrees till you hear a click. And after a few seconds, the LCD lights up. After that, you have to take the measurements within 2 minutes. The tip is advanced towards the surface of the cornea until you get a dark circle. The sensor tip is that green square which is seen at the center of the white circle, and that has to be centered in the center of this dark ring on the surface of the cornea, and not at the pupil is not used as a centering. So this is a short video which shows a patient position at the slit lamp. The tonometer tip is against the surface of the cornea. Once the accurate measurement is acquired, a continuous beep is heard. You wait for about 5 to 7 seconds before you pull the tip away. You can see this dark circle, and now the sensor tip is at the center of the circle. The LCD lights up, and this is what you see. The diastolic intraocular pressure, the quality score which varies from 1 to 5, and the ocular pulse amplitude. Since this takes rapid measurements of about 100 measurements over a period of 1 second, you get both the diastolic intraocular pressure, the systolic intraocular pressure. So the difference between the two gives you the ocular pulse amplitude. The quality score is mentioned here. You should get about 1 or 2. So how do we compare this with the Goldman application tonometry, which is a gold standard in both healthy and glaucomatous eyes? So this was a study done in about 300 patients, and you can see here that the DCT values were always a little higher than that of the GAT. The mean difference was found to be a little higher in healthy eyes. So this was the same study. They found that the magnitude of the difference in intraocular pressure between the GAT and the DCT decreased with increasing central corneal thickness as well as with increasing intraocular pressure. And the central corneal thickness did not affect the DCT measurement significantly, whereas it did affect the Goldman application tonometry measurements. Age, axial length, and corneal curvature had no influence. So this was the large study based on the population-based study from the Latino eye group, and they looked at intraocular pressure measurements with the GAT and DCT in over 2,000 eyes, and again found that DCT measurements were slightly higher than that of the DCT measurement was slightly higher than that of the GAT, and while both did increase with increase in central corneal thickness, the DCT measurements were not influenced as much as the Goldman application tonometry. Or when it was corrected for central corneal thickness, the DCT measurements appear to be slightly affected by central corneal curvature. This was a study which compared the DCT measurements with intracameral intraocular pressure measurements when the antechamber was cannulated prior to phacoemulsification surgery. And they looked at factors which could affect intraocular pressure, such as age, astigmatism, accident, and central corneal thickness. The IOP was set at 15, 20, and 35, and you can see that the measurements correlate quite well with the intracameral measurements and with the DCT. However, with higher intraocular pressures, there was more of a spread. Around 35 millimeters mercury, the values were not as close to the mean as with the intracameral measurements. We also need to know the precision and accuracy of each instrument that we use. And this study comparing measurements with the GAT, the DCT and the ORA, the DCT measurements had far less variability within observer compared to the other two instruments. Similarly, when they looked at inter-observer agreement, the DCT again had less variability compared to GAT and ORA. They also looked at the influence of the corneal resistance factor on IOP measurements, and it was found that with lower CRS, the GAT underread measurements, and with higher CRS, the GAT overread measurements. You get changes in corneal biomechanics when LASIK is performed, and we all know that there is a reduction in the central corneal thickness following LASIK, and this will influence your measurements of IOP before and after the procedure. And again, this study found that in 66 myopic eyes following procedure, the DCT had the least change, both in the average change as well as the absolute change compared to the other two instruments. And this is illustrated by this case report of a 51-year-old lady who had undergone LASIK surgery about 10 years prior to her visit at our center. And you can see the advanced glaucomatous optic nerve damage. She had tubular fields in both eyes. You can see the gross underestimation in GAT in both the eyes in this patient compared to both the DCT and the corneal composite reading of the ORA. When comparing the DCT with the GAT in patients following penetrating keratoplasty and DLEK, it was found that again the IOP was with the DCT was slightly higher, and the magnitude of the difference decreased with increase in intraocular pressure. This was another study which looked at IOP measurements in pathological corneas. 171 eyes with corneal pathology and 26 controls, out of which 95 eyes with penetrating keratoplasty were the largest group. They compared the rebound tonometer with the GAT and the rebound tonometer with the DCT, and it was found that there was a narrow spread of measurements when you compared the RT with GAT, but a much wider spread of measurements when you compare RT with DCT. Measurements were possible in 100% with the rebound tonometer, 98% with the GAT, but only 73% with the DCT. We have additional information on the ocular pulse amplitude with the DCT, and we know that it is a surrogate measure of the ocular perfusion, which could be one of the pathogenetic mechanisms for progression of glaucoma. So this group looked at the OPA in patients with glaucoma, ocular hypertension, and normal eyes. And surprisingly, they found that normal eyes had lower OPA compared to the other two groups. And this is in contrast to another group which looked at measurements with the handheld DCT compared with the other two, and found that patients with NTG had a reduced ocular pulse amplitude. So in conclusion, DCT provides IOP measurements close to true intraocular pressure, which are both repeatable and reproducible. Measurements are less affected by corneal biomechanics compared to the other tonometers. However, the role of the OPA measurements obtained is still a little controversial.